so we're going to discuss the session on the 2018 classification. What have we learned? I'm here with Mariano Sanz and Maurizio Tonetti. Maurizio, just to start with, we're now 7 years on from the classification. How has it become embedded and used in dental world and in the broader health professions world?
So the first important thing is to say that 7 years on, it has been a success. I am very happy to see the way it has transformed the practice and in the way it has opened new avenues in the medical-dental collaboration, better patient communication, possibility of new models of care and new models of reimbursement of periodontal procedures. So all in all, 7 years on, I am very happy to see what has happened. There is still a lot that needs to be done, but we are at a good stage.
Good. Okay, and Mariano, I suppose one of the aspects was that the classification hoped to personalize the approach to healthcare by considering complexity of disease management and the possibility of future progression. So how do you think that aspect of personalizing the approach through diagnosis and treatment has worked so far?
Well, I think we shouldn't see the classification in isolation. So the classification, I think, has been a fantastic tool to move forward towards guiding treatment. And I think we need to put the context of the classification with the context of the clinical practice guidelines, where the classification is the basis for analyzing the evidence behind the different interventions that we do to treat our patients. Because by staging and grading our patients, we can really focus on what it is efficacious and how we should undertake the treatment. So the way we have agreed on a stepwise approach to periodontal treatment cannot be understood without the classification, because the classification basically is what guides those steps in a rational way. And I think this combination of the classification and the clinical practice guidelines probably has moved periodontology in 8 years more than in the last 100 years.
And in terms of, we can think of that in a clinical sense, but in terms of research and epidemiology and how that can help us move forward further, how has the classification made changes in those areas?
So I think the classification has asked the questions. Is it enough to tell what is the prevalence of periodontitis? What is the prevalence of gingivitis? The answer is obviously it's not enough. It's not enough to manage the disease in a population. It's not enough to plan the workforce. It's not enough to plan the training of general dentists and specialists worldwide. So in this respect, the classification has put a lot of question marks. Now, new studies will have to give us the evidence about the prevalence and incidence of different stages and grades of periodontitis. We are still in the infancy, but I think that in the next 5 years we will have decisive new information that will really help inform not only practice but policy.
Okay. And Mariano, do you think then, taking on that on a classification or on a policy level, why is the classification important in harmonizing how we apply our efforts towards oral health being recognized as a more major part of overall health at a policy level?
I think it's very important because, as you see, when we analyze periodontitis being so prevalent in the population, we have the tendency to look only to severe periodontitis. And this is absolutely wrong, because most of the periodontitis that is there is incipient periodontitis, which is what we should focus if we want to have a population health approach. So in that way also the classification helps, because we can compartmentalize the disease and focus us on the early disease stages, because that's where when we can be really efficacious, not only in terms of therapy and prevention, but also in terms of the associations that we understand it happened with systemic diseases. Because if we only focus on the very severe periodontitis, the problem is that also from the medical way, in one sense there is no controversy at all whether periodontitis drives systemic inflammation and so on and so forth. But on the other hand, the medical profession is looking at us, asking, why are not you more efficient in not getting there? And I think in that sense, classification really helps.
I think there is a very important point, and it is that the classification actually summarizes the disease trajectory. People don't start with stage 3 periodontitis. People start with gingivitis that converts into early periodontitis, the stage 1, and then stage 2, 3, and eventually 4. And it is this disease trajectory that has a medical implication that go beyond inflammation and infection. When we get to stage 4 periodontitis, the impact on nutrition, the impact on strength, the impact on aging become things that are obvious but have been neglected until now.
So the most recent EFP workshop was on the consideration of new diagnostic tools and technologies. How do you think these can have the potential to impact this conversation in future?
Well, I think the workshop helps us to basically have two pair of glasses. One pair of glasses is looking at the past, and another pair of glasses is looking at the future. If looking at the past, probably we have to recognize that we have not been very successful in developing meaningful biomarkers. But probably because we were looking at the biomarkers in isolation. Nowadays, we have the tools. Now we are putting ourselves the glasses of the future, of not looking at the biomarkers in isolation, but looking at how we can cluster the biomarkers, how we can use AI tools to help us evaluating that data that becomes meaningful from a patient treatment perspective. So in that sense, I think the workshop has been very useful to understand what we know and also to understand what we need to know.
Okay.
Yes, and also the workshop has been particularly useful from a methodological standpoint, because as we want to move forward, we need to have a few things that are clear. And one has been the definition of the standard. Whenever we evaluate a new diagnostics, we have to have index test, the test that we are testing at the moment, but we have to have a reference standard. And making clear that we know what are the reference standards, I think this has been a major step forward that was not a given. And much of the difficulty of the previous research has been not using clear, accepted reference standard. So that I think it's very important. The other element that I like very much from the workshop is the fact that it gives us an overview that has no mercy. And by no mercy, I mean that on one side, we put an end to a lot of things that didn't work particularly well. And we look to the future having matured, having learned from what didn't go wrong with the diagnostics that we attempted to develop until now. So I have great confidence that within 3 to 5 years, periodontology and periodontal diagnosis will be transformed by the classification, by the diagnostic workshop, and by the research that is ongoing today and will give outcomes in the next 3 to 5 years.
So I'll finish with a two-pronged question. Looking back before the World Workshop meeting that drove the classification, there were probably a number of factors that directed this impetus to make a change. So looking at it 7 years later, are there unrealized hopes or expectations that we have to focus on to improve further? And on the other side of it, are there areas that you feel really offer us a clear future direction?
I have one unrealized hope that, in my opinion, should be high on the policy agenda. So when Ken Corman, Henry Greenwell and myself discussed the framework for staging and grading, our wish was to see this framework translating into a new repayment system. So in aligning the schedule fee, what the insurance companies will pay back to the dentist and the periodontist, to the complexity, the severity, the time needed to be able to treat these cases. I think this is necessary, and I hope to see it. In the classification, it's already built in that we could have not procedure codes, but we could have disease treatment packages that will require different efforts, different skills, and should be compensated with different amounts of money.
Now, from my perspective, in one side, a major step forward was to shift from looking at severity and extent only to considering complexity and to consider what are the factors that are critical in our communication with the patient of the amount of therapy that needs to be done and how this therapy is rendered. This classification, the staging system, provides a beautiful manner that probably was not invented by Maurizio and Ken, was transported from the medical field, where the staging system is a very straightforward communication tool to understand what it needs. Probably the issue that we still are lagging behind is the issue that we put a lot of high hopes on the grading system to drive personalized periodontology. And the idea is there. It is built into the classification through the grading system. Probably we realize now, after 7 years, that we do not have those biomarkers, those tools that guide us to understand what is the inherent risk of a particular patient to drive our therapy different because of their risk profile. I think we need to do much better in that, and I'm sure that we will soon have more tools to help us basically to personalize our treatment.
Okay, thank you both. I know that the classification expressly desired to be a living classification, so I think we can see that there's something that's very clearly alive and maybe also still evolving. So thank you for your time.
Thank you. Thank you.